My name is Ria James. My husband Reese was 36 when he was diagnosed. We weren't really the kind of people to mope, so we got out, we did as much as we could. We ended up with 22 months that we weren't banking on, so that was great. He wanted to spend as much time with people as he could, which we did, and he wanted to get married, which we did. He was 37 when he died from stage 4 adenocarcinoma, which usually is a very old lady issue, which was fun to take the mickey out of him with. It was difficult. Had to have a lot of time off. It was pretty much just the two of us. Ideally, Reese would have died at home. That's what he wanted. We started to consider hospice care under advisement because by that point his medical needs were getting quite large and I was struggling. It would have been a lot easier if end of life planning had been from day one. By the time we were thinking about it, he was so poorly that it felt like this is the point at which we give up, and it was a massive barrier. It was a really hard conversation to have because it felt like the end. It hadn't been natural.
My name's Peter. I live in St Helens. I've lived here 30 odd years. By trade, I was a cabinet maker. I wasn't actually working with asbestos, but I was in areas where the asbestos was prevalent. Hence I got my cancer through the civil service working, if you like.
Both Dad and I are very open with our feelings with each other and talking about end of life, and Dad stated that his main fear of dying was he didn't want to die in pain. It was also discussed of where Dad would like to spend his final days. If it's at all possible, he would like to go to the hospice because it is such a nice, calming, peaceful place, plus a very positive place. Anything that's within my power to do to make him happy and to give him the life he wants now, we will do.
When you see somebody die in the way that they wish to with the family in the most perfect way, it's the most empowering, wonderful thing that you can ever do. So that's where you get joy from it. And if people could only see that a death can be a good one, I think that it'd be a lot more passionate about it.
Advanced care planning is a form of planning with and for patients that really derives from the Mental Capacity Act in 2005. The aim is to make sure that we respect patients' autonomy. The difference between advanced care planning and other forms of care planning is that it does anticipate that the patient's condition will worsen. There are many perceived barriers to starting ACP conversations. One major one, I think, is that as health professionals we like to encourage a fighting spirit amongst patients, which is all very good, but it can at times cause problems because ACP conversations don't start. There's a fear that we may erode hope in the patients, and actually this isn't really backed up by research evidence.
The erosion of hope is something that a lot of health professionals really do worry about. It certainly, I don't think erodes hope. I think certainly doesn't increase anxiety. It's much more about that person being aware that perhaps not now, but later on we could do this.
My status is I have got triple negative metastatic breast cancer, which basically, metastatic basically means now it's back, you're going to die. Actually, end-of-life care is something I don't even know anything about. I met with the district nurse. She said I didn't want to. You're positive, you're healthy, you're looking forwards. Why would we talk about dying? You're not ready yet. I don't know when the right time is. Do you do it when you're healthy? Do I do it now? I also know that my children are too young to deal with it, so my wishes have to be known. And I think I need the right support to go through that process, which I don't have yet.
When you have families that are particularly fixated on don't ruin their hope, don't ruin their hope, and you're trying to support them with having open conversations, it's about saying, look, we're behind you here, we're passionate about supporting you, but through our experience of working in community settings, we don't want you getting into a position that could be avoidable.
It needs to be a little bit more adaptable, because they were giving him a very soft sell and he was so stubborn he was never going to accept it. So in the end it was left to me to be the really blunt one. And I did take the doctor to one side and I was like, you are not getting through. I need you to be a bit harder on this.
Any interaction between a healthcare professional and a patient is an opportunity to offer ACP conversations. If that offer doesn't take place, it can be a missed opportunity that may not represent itself.
When people are sick, they don't necessarily want to address that quite reasonably. I think when they're well, they don't necessarily think about it. They're on a roller coaster anyway, and if you don't address it when those opportunities arise, when someone's ready to talk about it, they get pushed to one side, and then you go to the next, you follow a protocol, you go to the next thing, you go to the next thing, and the opportunities become less frequent.
Staff are unsure about who should take responsibility for advanced care planning conversations, but it's my belief that any communication skill training that most healthcare professionals have is certainly adequate to get these conversations started.
At the end of the day, it is not one person's problem. It is the specialist nurses, specialist consultants, and even in the ward situation, it may even start with the physiotherapist. It starts as a team, and that's what our team has achieved in our ward.
If you are regularly undertaking advanced care planning with people, your confidence will grow, your understanding will grow, and your overall knowledge will become greater.
My advice to other healthcare professionals who are involved in ACP discussions and who might feel a bit anxious about that is not to feel anxious. For me, it's about meeting people on a real human level. I want to emphasise that this is not necessarily about dying, this is about living, but living in a way that's acceptable to them, where they have got choices and that we are doing what is important to them along that process.
And it's okay to say to people, I'm not actually sure about that, or I haven't been asked that before, but I'll go and find out and speak to some people and come back. People are happy enough for you to do that rather than just say, no, I don't know.
Most patients don't know about the benefits of ACP and what ACP could do for them. As healthcare professionals, we have a responsibility to try and change the culture to improve the way ACP is delivered so that more people get the benefit of what ACP can do for them.
Don't get me wrong, not all the help was bad and there were some spectacular individuals involved, so it's not all negative. I just think there is improvements that could be made there.